Hi, in part three of our lecture on neuromuscular disorders, we're going to talk about conditions that affect the motor pathways. So it's a good opportunity to remind ourselves of the motor pathways. So for muscles of the head and neck that are going to be served by the cranial nerves, we have the corticobulbar tract, which you can see over here on the left. So our upper motor neurons are of course, in our primary motor cortex. They're going to send their axons, through the corticobulbar tract, and then they're going to synapse down here in a cranial nerve motor nucleus, depending on which cranial nerve it is. And then that lower motor neuron is going to send its axon out to whichever muscle we are moving. For the rest of the body, the upper motor neurons are again in the primary motor cortex of the frontal lobe there. They're going to send their axons down through the midbrain into the medulla, where then they're going to cross or decussate in the medulla and then descend through the spinal cord. Descend through the spinal cord in what is called the lateral corticospinal tract. They're eventually then going to synapse with your lower motor neuron, which is going to be sitting in the ventral horn of the spinal cord, and its axon is going to leave through the ventral root, join a spinal nerve, and then go out to whichever muscle you are signaling. So hopefully that was useful. So we talked previously about upper motor neuron syndromes when we talked about stroke and cerebral palsy. And we talked about how with an upper motor neuron problem, you have this increased tone because the upper motor neuron is not functioning or its connection has been severed. So you don't have that tonic inhibition. So the muscles tend to have increased tone. You also tend to have increased reflexes. For this reason also, that has to do with some chemicals that are secreted by lower motor neurons, the muscle mass doesn't decrease significantly. It will definitely decrease some, but not as significantly as in a lower motor neuron problem. So in a lower motor neuron problem, we see the opposite. Hello, Oliver. So we see obviously weakness or paralysis. You're going to see that in both of them, but we're going to see decreased muscle tone. So instead of being stiff, the muscles are really soft and really floppy, like a rag doll. We're also going to see a decrease or absence of reflexes, and the muscles are going to waste away. So the muscles are going to become very, very small because they're not getting the same type of chemicals that they normally receive from a functional lower motor neuron. So as we look at disorders of the pathways, depending on whether it's an upper motor neuron or a lower motor neuron that has been disturbed, disrupted, or diseased, we're going to find different types of symptoms. The first condition we'll talk about is amyotrophic lateral sclerosis. It's also known as Lou Gehrig's disease, or ALS. Amyotrophic, the prefix a means without, myo means muscle, trophy means growth. So amyotrophic means you are losing muscle. Lateral comes from a reference to the lateral corticospinal tract, and the word sclerosis means scarring. So that's how this condition got its name. What is this? This is another progressive neurodegenerative disorder that is also ultimately fatal. We're not really sure what causes it. A lot of people are working very hard on it, and we have at present no cure. Now, what's interesting about this condition is that you get destruction of both upper motor neurons and lower motor neurons. So you can get one and the other. So what are the symptoms? Well, it tends to have a gradual and progressive onset of weakness and then paralysis. It might be a flaccid, flappy paralysis from lower motor neuron, or it might be a tense, spastic paralysis from an upper motor neuron. And eventually, as you lose the ability to use your muscles, you lose the ability to walk, and to talk, and to move, and to eat, and then ultimately to breathe on your own, because the diaphragm is a skeletal muscle. It requires these motor neurons to tell it to contract. So The treatment for this, unfortunately, again, we have nothing that can cure it. So it's mainly supportive therapies to manage symptoms and maintain quality of life. So if you've ever seen people with those touch pads that can speak for them, if they've lost the ability to speak for themselves, certainly motorized wheelchairs, other types of adaptive equipment, sometimes feeding tubes, or sometimes people with ALS will go ahead and go on a ventilator so that they can live longer. A lot of people choose not to. So that's ALS. Another condition that can affect both upper and lower motor neurons is spinal cord injury. So I've kind of taken our previous diagram, and the cat's sitting on my glasses, and added to it a little bit. So I added another spinal cord level because I think that'll be useful to us. So let's just remind ourselves, here's the upper motor neuron axon coming down, decussating in the medulla, going down through the lateral corticospinal tract. And let's say that this one is going to synapse with this lower motor neuron here, which is going to send a signal to, I don't know, the hand. There's a hand. Okay. But let's say we've got another upper motor neuron sending its signal down, going through the lateral cortical spinal tract, keeps going down to get to this lower motor neuron, because this one is maybe then going to contract the foot. All right, that doesn't look like a foot, but okay. So if the injury that occurs is at the level of that motor neuron up above, if it's here, if the injury is here, then I have injured the upper motor neuron that supplies the hand. That's supposed to be a hand. So at the level of the injury, I'm going to have a lower motor neuron syndrome. So I'm going to have a flaccid paralysis. I'm going to have decreased tone. I'm going to have decreased or absent reflexes. But below the level, down here, let me change color. Down here, what I've lost is my connection from the upper motor neuron. My lower motor neuron is fine. So down here, I'm going to have an upper motor neuron syndrome. So down in the lower extremity in the foot, I'm going to have spastic paralysis, increased reflexes, increased tone. So spinal cord injuries are really interesting in that way because you're going to get a mix. Just at a very precise level, you're going to have that lower motor neuron syndrome, but everything below that, you're going to have an upper motor neuron syndrome. We can also have an injury to a peripheral nerve. So again, we've got two different things. We've got a corticobulbar tract and a corticospinal tract shown here. Here are my upper motor neurons. Here is the lower motor neuron in the brainstem, sending its axon out through a cranial nerve. And then down here, I have my traveling down through the corticospinal tract, getting to my lower motor neuron, which is going to send its axon out through spinal nerve. So remember, these peripheral nerves, whether they are cranial nerves or whether they are spinal nerves or branches off of the spinal nerves, they are what contain the axons of the lower motor neuron. So if you injure one of these peripheral nerves, you're going to have a lower motor neuron syndrome with flaccid paralysis and decreased reflexes. So when we learned about sciatica, when we learned about the peripheral nervous system and nerves, so the sciatic nerve, you may remember, supplies the posterior thigh as well as all of the lower extremity from the knee down. One of the things, many different things can irritate or cause problems with the sciatic nerve. One is a herniated disc, which they're showing you here. So this is a side view of the spine, and one of the little intervertebral discs is actually pushing on one of those nerve roots and compressing it. So if that happens, those are the axons of the lower motor neuron that are coming out. So you can get a lower motor neuron syndrome. When we talked about sciatica, we talked about how it can cause pain and sometimes weakness. So if the impingement or pinching or pressing on the nerve root is severe enough to interfere with the motor axons, then you're going to get this lower motor neuron syndrome. Another example that we already talked about is Bell's palsy or facial nerve palsy. So remember, that's dysfunction of cranial nerve 7, the facial nerve, which carries the axons of the lower motor neurons for movement of the muscles of the face. And so when you get that facial paralysis on one half of your face, again, you've got that paralysis or weakness of the muscles, and they're going to have decreased tone. So in summary, you can have upper motor neuron or lower motor neuron syndromes depending on exactly which part of the motor pathway is involved. In amyotrophic lateral sclerosis, or ALS, you can have both upper motor neurons and lower motor neurons being destroyed in this disease. So depending on what's going on where, you can have a variety, constellation of different types of symptoms. But it is a progressive neurodegenerative disorder, eventually resulting in paralysis, including of the muscles needed to speak and eat, as well as the muscles needed to breathe. Spinal cord injuries will also affect both upper and motor neurons. So at the level of the injury in the ventral horn of the spinal cord there, that's where the cell body of the lower motor neurons are. So at that level, it's a lower motor neuron syndrome. But below there, we've basically cut off the axons that were coming down of the upper motor neurons. So from that level below, it's an upper motor neuron syndrome. And then lastly, peripheral nerve conditions, whether it's a spinal nerve or a facial nerve, that's going to be a lower motor neuron syndrome because those nerves are carrying the axons of the lower motor neuron, either coming from the brainstem or from the spinal cord. So two examples that we talked about previously were both sciatica and facial nerve palsy, and so you will have paralysis with decreased tone. All right. We have one more section left, which is disorders of the neuromuscular junction. See you there.